definition of subtyping recurrence is with hiatal or anti-reflux surgery. That's missing. Who should be doing it? You know, if you've done a primary anti-reflux fundo once and it's failed, doing it again is likely to fail. So again, we don't have a picture in the UK who's doing revisional, what are their outcomes, etc., etc. So hopefully I haven't switched you off too much at this stage. So I won't go into this in too much detail because these definitions are around in the literature. But basically, primary anti-reflux surgery fundoplication is always elective. You would never do this as an emergency because it's a lifestyle anti-reflux operation. It's associated with a small hiatus hernia, as about 80% are. If you pick up the phone and say, "Oh, Mr. Andrews, I did a primary anti-reflux operation on Mrs. Jones and it worked," I know exactly what you've done on using this definition rather than what we have at the moment as a vocabulary. Links has got a very similar definition, obviously with the addition of adding a prosthetic implant. So when you talk to me about a primary anti-reflux operation, fundoplication, that is the patient that I'm looking at. It's elective. They're smiling because they're going to get rid of their reflux, which is pretty horrible. They don't have to take a PPI and guzzle Gaviscon. The median age from the Lotus and reflux trials for this type of patient having this type of procedure is 45. From the National Hiatal Surgical Registry, which has just come online, is now churning out really good data. It has a similar conclusion. It came to an average age of 48, I think. You would expect the morbidity and mortality of this operation to be super low. You cannot kill people with this operation. You shouldn't harm them. Otherwise, I'd rather take my PPI mate. And we should be delivering this kind of surgery as a day case, or at least short stay overnight. So I'm beginning to build a picture, an understanding of what we're talking about with hiatal surgery. Yeah. You pick up the phone and say to me, "Oh, Mr. Andrews, I've done a primary hiatus hernia repair and I need some advice because there's some problems." I know exactly what you're talking about. First of all, it could be an elective or an emergency patient. As I said, a lot of mine are emergencies. They come in covered in black vomit because they got a volvulus which has been decompressed either with OGD or an NG tube, although elective admissions are true. But look at that patient. They're a good 20, 30 years older. And again, NHSR, National Hiatal Surgical Registry, reports this, as do other studies which know what they're talking about and properly classify. This operation does kill people. It does have a mortality. It's a very different conversation that you have with your patients. It has a very different objective. Most of it is to cure iron deficiency anemia, shortness of breath, volvulus episodes, reflux. But the stakes are higher in this operation. And to try and mix the two together is like diluting hot water or boiling water and cold water. They're different pots. You just get something lukewarm in the middle with mixed data, which doesn't mean anything. So if ever you need to look at your outcomes, you need to look exactly what the operation is that you have done. And we're not doing that. We are not doing that at a national level with the current codes that exist. That is under review at the moment. Again, I won't bore you with this wordy slide, but basically it talks about the hybrid patient where they've got a large hiatus hernia, but you are chasing reflux. They're a subgroup that are emerging. And as you can imagine, they're somewhere in the middle in terms of their age range, morbidity, mortality. And you'll see data coming out of the National Hiatal Surgical Registry with regard to this. And again, we need to have a system because obviously you're going to be repairing the hiatal defect after you do these operations. So again, we need a really simple way, really simple classification of measuring that defect. And again, if you look at the Orgis bug subsection, you will see that classification spelled out for you to make it very easy. Whether you use mesh or not to repair these hiatal defects, there is no evidence. There's no direction or guidelines for it. So you're talking rubbish, Mr. Andrews. I don't believe anything that you've said. Well, that's fair enough accusation. Well, let me show you a paper. So Portsmouth, huge hiatal unit. They churn out vast amounts of hiatal surgery for relatively recent publication. So their headline title is Technique and Outcome for Day Case Laparoscopic Hiatus Hernia for Small and Large Hernias. So that title, from the beginning, doesn't make sense. What does that mean? We've just defined primary anti-reflux surgery as an elective, small hiatal defects, small hernias. So the title of the publication doesn't make sense. The conclusion, laparoscopic anti-reflux surgery. So we've now moved into anti-reflux surgery. We've chopped and changed between that and hiatus hernia surgery can be delivered. Well, let's look at their outcomes. So this is what has been published. So we've got hiatal size, hiatal or hiatus hernia size. They haven't really stated how they've measured it, but let's just say take it at face value. So small hiatus hernias, as we've said, they are associated with what we would call primary anti-reflux surgery. They've got a fantastic day case rate of 81%, which is what you'd expect. But when you look at large hiatus hernias, which we would call primary hiatus hernia, their day case rate falls to 2%. So it's a very confused publication. And I'm not picking on Portsmouth because they're a great unit. I know the guys there very well. But what it does is it makes an example of how we don't in the UK have a common vocabulary for this subset of surgery. We don't, up until now anyway, we don't have a common vocabulary. We don't have a capturing system to validate quality. So these are, remember, a quality of life operations. So their value is based on how good a quality of life your patient had before and after the procedure. And not only do you need to know that in the short term, but you need to know that going 4 or 5 years out. Not knowing if your primary anti-reflux operation has been effective for your patient at 5 years is the equivalent of a cancer surgeon not knowing their survival rate at and recurrence rate at 5 years. It's equivalent of a bariatric surgeon having no idea what the average weight loss of their patients who they've performed bariatric surgery is 5 years out. Incredible, isn't it? An incredible defect, an incredible gap that we have at a national level in this subset of upper GI surgery. So the National Hiatal Surgical Registry has come on board. First annual report was last year. The second annual report is due at the August conference for those of you going. And again, it's giving you a glimpse of outcomes of this type of surgery and bringing it and making it credible that the UK as a healthcare service actually takes this kind of surgery seriously. Well, there you go. I've whizzed through that in super time. I assume you've all logged off. I don't know. Let's find out. There we go. Any questions? Professor Bowling has a question by the looks of it.
Can you hear me, Stuart?
Yes, Mr. Bowling. Hello.
Hello. Very good presentation. So I just wonder, in your own opinion, if a centre like Portsmouth, well, I mean, we do pick on Portsmouth, but like Portsmouth, is churning out 500, 600 hiatal hernia anti-reflux procedures a year. If they don't know their PROMS outcomes, what's the validity of them being a major centre in terms of hiatal surgery, in your opinion?
Well, I mean, doing 500 things doesn't mean you're good at them. So you have to have outcomes. You have to validate your data, and that you can't mark your own homework. So I think if you're going to be taken credibly as a unit, you need to be able to show that your outcomes are good. And those outcomes need to be independently validated. I think patients, particularly in this aspect of surgery, are becoming more astute to that. If you've got cancer, you're so focused on getting it done, you're less focused on quality. Certainly, if I had severe reflux and I was guzzling PPIs and an alginate, I would seriously want to know how many procedures my surgeon does and what do his outcomes look like. And I can guarantee you that the majority of surgeons in this country couldn't answer those questions. A question's popped up in the chat. What's the uptake of the registry? Well, I can tell you that currently it's got 600 patients registered from 70 centres across the UK. The reports are publicly available, so if you log on to the National Hiatal Surgical Registry site, you can download the report. But yeah, no, it's bonkers, isn't it? Really, that we don't know. So a couple more questions have popped up. So first one is, interestingly to see that your definitions do not specify or subdivide by type of fundoplication. Is this an important distinction? Yes and no. So a fundoplication obviously is you have wrapped part of the stomach around the lower esophagus. Now, we could debate all week what type of fundo is best. And the National Hiatal Surgical Registry will be able to split that down into partials, completes, etc. So to answer your question, it's yes and no. But there's decades of publications about what kind of fundoplication is best, and there is no clear answer to the outcome. So that's why we have bundled it all together, because there's no real answer to that. And no one can argue that a 360 is better than a toupee, and vice versa, because there's a wealth of data to support both sides. One common question I get asked is, what are the long-term complications of a PPI? I have no idea. Ask a gastroenterologist, I guess. So I know that the data says that somewhere between 10 and 15% of people get a significant complication with a PPI, be it myalgia, skin rashes, sensitivity to sunlight, blah, blah, blah. So at least 10% of my fundoplication practice is on patients who are intolerant of PPRs. And then in terms of long-term health risks, osteoporosis, etc., etc. So yeah. Mr. Bowling, you had your hand up?
I think there's other questions before me, Stu.
Oh, right. Another one's popped in. Should patients getting a cardiomyotomy get a fundoplication? No idea. Probably yes. So if you look at Poem, for instance, which cannot physically do a fundoplication because of the modality of its action, if you look at those outcomes in terms of their swallowing Eckardt scores, they're equal to a Heller's cardiomyotomy. However, their reflux scores are higher. So probably that is enough evidence that cardiomyotomy should get routine fundoplication. Certainly all surgeons I know and have trained under have always done it. But who's to say what's right or wrong? I think the most important thing is don't make a hole in the esophagus. Mr. Bowling?
So one of the things if you look at things like the Lotus trial, one of the things that's inferred by the Lotus trial is that PPI use after anti-reflux surgery is a failure. In your opinion, do you think someone being on a PPI is a failure of anti-reflux surgery?
Don't know is the answer. I suppose I would fall back to the position that I've taken as being heavily involved in the National Hiatal Surgical Registry. The only thing that matters at the end of this operation is if you've improved their quality of life. And I always say that to patients during consent process, that overall, I'm likely to improve your situation. However, I might enhance some of your symptoms like pain, gas bloat, dysphagia, but I might also, or I aim to significantly improve a lot of your other symptoms. But you will never have the gullet, a perfect gullet. You can't do it. So whether the use of a PPI after a primary anti-reflux operation is a failure, I think you have to make your own mind up. I personally don't care. What I want to see is the graph. I want to see the graph of my patient's pre-operative quality of life score very high, and I want to see the post-operative quality of life score very low, and I want to see that remain low, going 1, 2, 3, 4, 5 years out. And that's exactly what the National Hiatal Registry will tell me as an individual surgeon, because it's a tool for the individual surgeon to be reflective on their own practice. But also on a national level, I would like to see what we are all doing at a national level. The thing that worries me most are the centres that don't submit data, I suppose.
Can I ask what sort of conversations do you have with people when you're approaching redo surgery or redo surgery, and what are the subgroup where you get to a point where you say, I'm not touching that, you've had too much? Or
Yeah, I mean, it's difficult. I mean, that question might be better answered by a high volume surgeon like Mr. Bowling than myself. I mean, the only thing that I will say is there's little point doing an operation that has previously failed. You can, and people do, but if the first one's failed, then what's to stop the second one failing? Unless it's been done, suboptimally. I have done a gastric bypass for a patient that's failed 2 previous redos. I did that very recently, and that was a success in the short term. But so it's a very difficult area of hiatal surgery, and that again is something as a surgical community we probably ought to improve on. Now, I probably would be an advocate of redo hiatal surgery being centralized to high volume hiatal units that take it seriously. And probably it should be a centre that offers the full breadth of options. So that would be redo fundo, that would be links, that would be gastric bypass, etc., etc. I don't know whether Mr. Bowling wanted to add anything to that.
No, I agree. I mean, there's no magicians out there, as a wise man once told me, and I think the if you just keep repeating the same thing over and over again, expecting a different result, you're going to be sorely disappointed. So I think it is really important, particularly with revisional surgery, you run it through an MDT with experienced hiatal surgeons, and you also take the patient through that decision-making process as to what the risks and benefits are of the various treatments. But to date, there has not been a wizard that stepped forward as having the one-all solution that can fix all these problems. As Stuart will, no doubt agree.
Yeah, no, absolutely. So there you go. That's my roundup of hiatal surgery. I think you're going to see changes with hiatal surgery in this country in the coming 5 to 10 years about how it's delivered and who delivers it. And I think we owe it to ourselves, or most importantly, our patients, that we are doing appropriate things and getting good outcomes and value for money for the NHS. I certainly remember being, as I said, left to do these operations unsupervised, and almost certainly all of them had recurrence at a year. I don't think this is given the focus and attention that it really deserves. Thank you very much.